So this is about non-tariff medicines, also known as non-payment by results, pass-through or high-cost medicines. The first thing is this applies to the NHS in England only, because that's how it works. So how does it work? A patient comes into hospital, we fix them using a box of tricks, and the patient goes home happy. So what goes into the box? Well, everything that we need to fix patients, so staff, costs of running buildings, medical kit, and because we're pharmacy, medicines. To pay for this, every hospital gets paid the average amount it costs to treat a patient with a condition, which is listed in the tariff, which leads us to lesson 1. If a hospital spends less than the national average to treat a patient for a condition, they make a profit. If they spend more, they make a loss. This is designed to incentivise hospitals to be more efficient and not waste money. But what if the average isn't fair? How couldn't it be fair? It's the average. So for some conditions, there's not much difference in medicines cost between patients. For others, there's a bigger difference, and for some conditions, a very small number of patients will need medicines that are very expensive, and these differences in cost can be really big. Which leads to lesson 2. For some conditions, the average patient is fairly average, but for other conditions, there can be huge differences in cost for similar patients, and this spend needs to be shared fairly. So to illustrate this, we'll look at 2 hospitals which are similar sizes, but maybe have different specialities. So looking at patients admitted with an MI, there may be a couple of patients who need more expensive treatments, but they are evenly spread across the hospitals, so the average payment is fair for both. The drug cost can be put in the tariff. For rheumatology, the patients needing expensive medicines are not evenly spread, so an average payment would be unfair. Hospital 1 would always make a profit and Hospital 2 a loss. So expensive medicines in rheumatology are non-tariff. Looking at primary care, the different CCGs will be sending patients to both hospitals. Use of the expensive stuff averages out across the CCGs, so it's fair for the CCGs to pay for the medicines in addition to the tariff payment. So for some things in haematology, the expensive medicines are used for much fewer patients, so use doesn't average out between hospitals or CCGs. In this case, NHS England would fund. So where does this leave us for lesson 3? If there's even use of a medicine for a condition between hospitals, it's usually in tariff. Otherwise it's non-tariff, and a hospital using it would get the tariff payment for treating a patient plus the cost of the medicines. If use is fairly even between CCGs, the CCG would normally be responsible for paying for the medicines. If not, it would come from NHS England. And why is this important? Because whoever pays for the medicine, the commissioner, gets to choose whether you can use the product. You need to ask the right people.